Welcome to CDP Presents, the monthly webinar series hosted by the Center for Deployment Psychology. We're happy to have all of you with us today, and if you've joined us before, welcome back. I'm Andy Santinello, Senior Military Behavioral Health Psychologist at the Center for Deployment Psychology at the Uniformed Services University and a member of the CDP Presents team, and I will be your host for today's webinar. This project is sponsored by the Uniformed Services University, USU. However, the information or content and conclusions do not necessarily represent the official position or policy of, nor should any official endorsement be inferred on the part of USU, the Department of Defense, or the U.S. government. Here's a nice snapshot of our upcoming training events. And so hopefully you'll be able to join us for some of these in the next coming months. We also have CDP Presents monthly calendar plan for the year 2022. We're just putting the finishing touches on that, so be on the lookout for an email announcement coming soon. Did you miss last month's webinar, Self-Empowering Addiction Treatment and Mutual Help? Well, never fear, we have you covered. You can find the recording on our webinar, our archive webinars page. If you've attended and liked the webinar, please feel free to share it with your colleagues and friends. Also, hopefully you're aware of this already, but very recently CDP launched our official podcast, Practical for Your Practice. And this bi-weekly podcast features stories, ideas, support, and actionable intel to empower providers to keep working towards implementing evidence-based psychotherapies with fidelity and effectiveness. In our latest episode, we sit down with Dr. Anna Brewer for a rich discussion about manifesting the spirit of motivational interviewing in the context of evidence-based psychotherapy. So be sure to check out that episode and other episodes on the podcast page of our website. And don't forget to subscribe to on your favorite platform. Now, just a few tips on enhancing your experience of today's webinar before we begin. You may have entered the webinar in full screen mode, and if so, please click on your screen and hit the escape key if you wish to exit full screen mode. For the best user experience today, we recommend that you close all other programs on your computer. Any difficulties viewing the material during the presentation are likely due to poor internet connection. While I'm talking, please check the volume level on your computer or device and adjust as needed. Many participants will find it easier to hear the presentation by using headphones. Please note the chat feature, which you can find by hovering over the bottom of the screen. This is a great place for you to enter questions and respond to questions that our speaker may pose, or even to interact with other participants. Questions will be moderated by me and asked of the presenters in the final 5 to 10 minutes of our presentation today. Also, if you experience any technical difficulties today, please type the problem in the chat pod, and someone from our tech support team will assist you. Please make sure that you send your text message to all panelists and attendees in the chat pod so that they can see your questions. This webinar series will be recorded and posted to the Center for Deployment Psychology website, along with any additional materials and references. Handouts for today's webinar can be found in your CE21 My Account page under this event. Finally, at the end of the webinar, our project manager, Mr. Micah Norgard, will provide information and instructions on how to obtain CEs. In order to obtain CE credit, you must attend the entire webinar and complete the webinar survey in CE21. Please note that for this webinar, we're offering American Psychological Association CE credits, which are acceptable to most state licensing boards for different mental health disciplines. Be sure to check the requirements for your state and retain any documentation associated with this training. Now it's my pleasure to introduce our speakers for today. Abigail Ancow is a consultant with the PTSD consultation program through the National Center for PTSD, clinical psychologist, section chief at the VA San Diego, and associate clinical professor at the University of California, San Diego. Her primary research interests include PTSD and co-occurring conditions, as well as improving the delivery of mental health treatment. Coming from a military family, Dr. Ankow is personally invested in helping providers through complex clinical and administrative challenges to provide high-quality care for veterans with PTSD. Dr. Ankow received her PhD from the University of Cincinnati and completed her internship and postdoctoral fellowship at the UCSD and VA San Diego. We also have Dr. Brittany N. Hall Clark. She's a consultant with the PTSD Consultation Program through the National Center for PTSD, a Texas licensed clinical psychologist in private practice, and an assistant professor within the Division of Behavioral Medicine and the Department of Psychiatry at the University of Texas Health Science Center at San Antonio. Dr. Hall Clark's research interests include acculturative stress, cultural identity, culturally sensitive treatment. She obtained her PhD in clinical psychology at the University of Texas at Austin. Dr. Hall Clark completed a 2-year fellowship with StrongStar, a multidisciplinary PTSD research consortium. So with that, I'm excited to hand things over to our presenters.
All right, thank you for that introduction, Dr. Santinello. I can see that we have a disclosure slide on, and neither Dr. Hall Clark nor I have any disclosures for this presentation. And we're very happy to have everyone here. It was really lovely to see where people are from, especially not just within our United States, but we've got some attendees from across the world. So that is really wonderful. And thank you so much for joining. Our lecture today is titled The Elephant in the Room, Treating PTSD When Clinicians Have Strong Reactions to Patient Sociocultural Views. And I realize you cannot see me, so I should have introduced myself. I am Dr. Abigail Ankow. I'm a psychologist and located here in San Diego. For our presentation today, we won't be focused on a specific directionality of patient sociocultural views or political views in terms of being liberal or conservative, but instead we really hope to validate if you or your colleagues have strong reactions or have had strong reactions, especially over the past couple of years, to patients sharing thoughts and beliefs that may or may not conflict with your own, particularly if you are feeling challenged or burned out with work. I'm honored to share today's lecture with my colleague, Brittany. And Brittany, did you want to introduce yourself?
Hello, everybody. Good morning or good afternoon, what time it is, wherever you're calling in from. I'm also happy to be here and have so many attendees. We invite you to listen and engage. We are setting an attitude of respect, and like Dr. Ankow said, we don't have a particular directionality, but this can be a sensitive topic and sometimes difficult to broach. So we want to acknowledge that from the outset and just encourage everyone to keep that respect in mind when asking questions. And we do encourage you to submit questions so that we can all learn from this experience.
Thank you so much. So we will be, we have a few sections to our presentation today. And so Brittany and I will rotate. I can see, I'm not sure if this slide is coming through clearly for you. It looks fragmented on my end, but this should be, here we go, a slide showing our PTSD consultation program. And so Brittany and I were introduced as consultants with the PTSD consultation program, and this really is the foundation for why we developed this talk. And I'll talk about this a little bit more, but part of our mission is to provide education based on what we're hearing in consultation. And the PTSD consultation program, some of you may or may not be familiar with, but we are, it began over 10 years ago in 2011. It was the VA's first consultation program. There are now several other consultation programs focused on suicide and substance use and all sorts of topics. Our goal specifically for the PTSD consultation program is to improve the care available to all US veterans with PTSD, regardless of where they access their services. So we provide free consultation and resources for community providers and also VA clinicians who are treating veterans across a wide range of topics that may come up in the course of caring for our veterans with PTSD. And you can see we routinely receive consultations about assessment and treatment or just educational resources. And the reason why we developed this talk was actually based on consultations that we were receiving. I think this may be the third disclaimer slide, but again, wanted to acknowledge that the views expressed in our presentation today are Dr. Hall Clark and mine alone, not the US government or our consultation program. We have several objectives for our presentation today. We hope to share and develop strategies that clinicians can utilize if they have strong reactions to patient sociocultural views, particularly if they're treating PTSD, although this could also, some of the skills that we'll talk about could be utilized even outside of PTSD treatment. We will share of different ways to do case formulation or case conceptualization of patients' views that they're sharing, either within or outside of a trauma framework for PTSD treatment. And we'll employ that case conceptualization or case formulation to determine when and how to address the views that patients may share within evidence-based PTSD treatment. And as I mentioned, we developed this lecture in response to difficulties that we're hearing from clinicians through the PTSD consultation program. And to lay the foundation for that, I don't need to, we're in a unique situation where everybody on this call has had shared and overlapping stressors over the past year, couple years now. And the COVID-19 pandemic began and amplified many of these shared overlapping personal, social, medical, political, and economic crises are really more than we can list. But a lot of these events have stirred up passionate feelings and at times divisive reactions, understandably, because there have been a lot of overlapping, very important events that have happened over the past few years. And uniquely, our mental health clinicians have experienced these large scale events alongside our patients or clients. And so that is a particular thing to note, especially with a change in the way that mental health was provided when COVID-19 started. So the American Psychological Association did a geographically representative survey in November of 2020, and they repeated it again in 2021. And essentially, we know that our mental health clinicians, providers are impacted by the pandemic. And so they made a few comparisons pre and post pandemic. And because this was the American Psychological Association, their participants that they surveyed were psychologists, but really this would be generalizable across social work, psychiatry, LPMHCs, really any mental health clinicians. They found that 62% of mental health clinicians were had more patient referrals than they did pre-pandemic. 47% reported fewer no-shows or cancellations, and the patients that they were seeing had more anxiety disorders and depression than pre-pandemic. That 39% of psychologists in general were just working more. They were seeing more patients overall than they were pre-pandemic. I'm sure some of you are probably listening to this from home because we know that about 96% of clinicians were now treating their patients remotely or providing telehealth services. And that at least, and I remember this statistic was from November, so this might be a little bit different, but 63% reported that providing telemental health or providing remote treatment was more challenging for them than doing in-person care. And important to note, and what I really wanted to highlight here was in November of 2020, 41% of psychologists reported feeling burned out. And now that we're in January 2022, I would be interested to see how that percent burnout has changed or has not changed. And burnout is an important concept to consider when we're talking about clinicians having strong reactions to something that a patient communicates, because we are all human, and the way that we feel is going to impact how we are able to help others and what we bring into the room. And so I hope not to read too much, but I do like this definition from the APA Dictionary of Psychology, where they describe burnout as physical, emotional, or mental exhaustion that's accompanied by decreased motivation, lowered performance, and negative attitudes towards oneself and others. And so I could pause there and, we could reflect, take a moment to reflect if that might be something that you may be experiencing, or something that you may have noticed in any colleagues or peers that you work with. We know that burnout results from performing at a high level until stress and tension, especially from extreme and prolonged physical or mental exertion or overburdening workload, takes their toll. And that burnout can be particularly acute in therapists or counselors who are doing trauma work. And so I can see, Meredith, you mentioned that phrase, compassion fatigue and secondary trauma, that is real. Yeah, and I see burnout is real. That is absolutely true. And we would expect that burnout may make clinicians more susceptible to difficulties while providing care. They may find themselves potentially more reactionary, or perhaps less able to maybe react in the way that they would have previously prior to the pandemic, especially if they're seeing more patients in a telehealth modality that they may find to be more challenging, and during a pandemic that's now well into its second year. So this is something that definitely wanted to kind of lay the framework of, when we're talking about clinicians having strong reactions, that this is really in the context of the pandemic, plus all the other things that have happened over the past couple of years during the pandemic. And one thing that we looked at within the PTSD consultation program was how the content of our consults changed during the pandemic. We actually pulled some qualitative data that we put together for the International Society of Traumatic Stress Studies to present in a symposium last November. And these were the 5 major areas where we noticed a change in consults, because we routinely have received consults over the past 10 years, but we definitely noticed kind of a change in the content of what people were asking. So first, we had many questions about higher levels of care, like how can I get my patient into an IOP program or into a residential program, because people were seeing patients maybe whose acuity levels had increased, maybe their PTSD had worsened because of the pandemic. And at the same time, some residential programs shut down, or they became very restrictive in their inclusion criteria because of the pandemic as well. So that became very difficult. Second, we received many questions about how to adapt and continue offering evidence-based psychotherapies during a pandemic, and whether we should at all. Should we be providing EMDR, CBT, or PE during the pandemic when there is such an acute stressor happening? So lots of questions just about considering EBPs versus focusing on more acute stressors. Adapting, lots of questions on how to adapt interventions for telehealth. So how can I do prolonged exposure in vivos when my patient is in lockdown and supposed to be isolating? And what are the ways that we can provide EMDR virtually? And we ended up providing a lot of consultations about kind of stress first aid and kind of using disaster recovery framework models. And third, we received many logistical questions about telehealth, like for those of you who do prolonged exposure, there's a session where you're supposed to show videos, and a lot of questions like, how do you do this when both of you and your patient are over video? How can you show videos? Some just very practical questions like how do you find fillable forms for the PCL5? And I'll definitely do a shout out to my Center for Deployment Psychology colleagues, because we would often refer to their website where you can find fillable copies of many assessment forms. Fourth, we got a lot of questions about race-based trauma and stress, including looking for resources, kind of best practices for trauma-focused care, questions just about criterion A and PTSD assessment related to racial trauma. And then finally, we had a whole kind of grab bag of COVID-specific questions. I noticed Michael McCarthy in the chat mentioned about increase in domestic violence, which was huge. We actually had a lecture specific to the increase in interpersonal and domestic violence as people were kind of had to isolate in their homes. We had a lot of questions about face masks, just new parenting challenges when patients were now at home with their children and perhaps having to help educate them, how to support healthcare staff, because a lot of clinicians found themselves in a place where they had to provide kind of stress first aid to colleagues that maybe were clinicians in an ICU or in a hospital system. Lots of questions about grief and isolation. And then one issue that continued to come up were consultation requests for helping clinicians who had strong reactions to something that their client brought up about current events. And I will say it kind of came to a head during the election of, what do I do? Or just kind of acknowledging, that somebody having a difficult time in session because of something that a patient was bringing up, and kind of, do I address it? Do I not address it? And this phrase is likely familiar, so you may be familiar with that phrase, the personal is political. And I want to come back to this because that the idea that the personal is political really refers to a theory that personal problems that we might see in mental health are overlap with political problems, and by extension, social problems and cultural problems. That's why we use the phrase sociocultural in the title of our talk today. So in other words, the personal problems that patients might share in mental health treatment when they say they're experiencing increased anxiety or depression, they may, and they very likely may be the result of sociocultural events, potentially several sociocultural events that are happening in real time. And we should expect patients to share their sociocultural views and beliefs in mental health treatment right now, especially with so many recent stressors that evoke strong emotions and potentially divisive experiences. So I'd like you to just take a brief moment to reflect to yourself, and kind of as we lay the foundation for our presentation today, that how has your clinical practice been impacted? I showed that slide about, the change in telehealth and seeing more patients or not, but maybe consider to yourself, how has your clinical practice been impacted since the pandemic began? And then also, how have patients' views about sociocultural events entered your work? Have they? Is it something that maybe you ask directly, or is it something that patients readily bring up in their sessions with you? So thank you for taking a moment just to reflect to yourself. And so it kind of that we know that burnout may impact a clinician's reactions to patients. And we also know that patients will discuss their sociocultural beliefs in mental health treatment. And you may have reflected on comments you have heard in sessions from clients, whether you're a psychiatrist or a social worker or licensed professional mental health counselor or psychologist. We created this lecture because we were hearing about these increasing difficulties, and we're having a lot of consultations about this. And I wanted to share some specific examples of things that we heard over the past couple of years. So some example kind of sociocultural statements, definitely statements about COVID-19. So somebody sharing that their patient said, "I don't need a mask, I'm not Chinese." And this actually, I recall, was a statement very, very early on in the pandemic when the kind of masking was very new. Or just a statement kind of assuming how you are because you're a mental health therapist. And so you must be fine since you're a therapist, or you must be fine since you're a mental health clinician. Statements about race and culture. So my great grandfather was Cherokee. I know about discrimination, or just using slurs or disparaging language, which may happen within or outside of the pandemic, but this is something that people brought up specifically more recently. Statements about policing. So I could be like Derek Chauvin, or statements, very political statements, or statements about rights, legal rights, either, focused on gun rights or gun control, or just asking you, like during the election season, like who did you vote for? And the clinician may be having a reaction to that. So here are some example reactions. So these statements may not generate strong reactions, definitely not in all clinicians, but they did for the specific folks who reached out to the consultation program. And then some of those reactions that they shared were feeling angry, offended, or disappointed, maybe being fearful of showing any emotion. They may, we definitely have some theoretical orientations where clinicians are taught not to show how they feel, attempting to hide emotions, feeling distracted and struggling to be present. I can imagine that might especially increase if somebody's feeling burned out. Clinicians shared experiencing cognitive dissonance. So they may have, a strong foundation and, trying to have like a Rogerian approach, like unconditional positive regard for their patient, but now they're having a strong reaction to their patient. So that is a kind of a dissonance feeling that might feel uncomfortable for the clinician. They might feel indifferent or detached. Maybe they're just used to it, feeling maybe, especially if this is happening with some frequency. I can remember some specific clinics and teams sharing that, this is these kind of repeated experiences. It became something that they started just, dismissing or minimizing it. So they're just so used to it at this point. And this is and then the last one is likely a phrase that most folks are less familiar with. So this mask of accommodation that Brittany will mention, but this is, we'll return to this reference a few times. And the mask of accommodation refers to a learned coping response that people of color especially have developed in response to invalidation. So if somebody says something potentially hurtful, they might flee to like kind of a false accommodating self, like it's okay or it's not a big deal, in order to suppress feeling hurt. And this definitely could be a protective coping response to be able to get through and still care for your patient, and at the same time be difficult for the clinician. And then we titled our talk "The Elephant in the Room." Both, this kept coming up, and this is it was a little bit tongue in cheek, but we really do mean that, that our mental health professionals are finding themselves charged with this really heavy responsibility of guiding others through this time with a pandemic, with a lot of loss and uncertainty. And clinicians may have some sort of strong reaction to their clients' views. And that elephant in the room, what we're referring to here is when people talk about an elephant in the room, it's an obvious major problem or issue that people may not talk about or that they may avoid acknowledging. So in the context of our talk, the elephant in the room is that therapeutic impact of the clinician's strong reaction, which may include having a secondary reaction to their strong initial reaction. So, let's say that they found themselves feeling irritated, and now they might feel some doubt about themselves, or might even feel ashamed or guilty that they had a feeling like that about their client, because who they care for. And then if the clinician's own beliefs may differ from the client's, or if the client was specifically asking them what their beliefs are, they might can wonder and have a lot of questions, or just feel confused, wondering, should I share that I disagree? Should I disclose anything at all? If they're having a feeling offended or angered, they might wonder, how can I, or can I at all effectively work with and help this patient or client? We heard a lot about confusion. So confusion about their reaction, because there are just so many dynamics in a mental health session, and a lot of dynamics about why people have the views that they have that we want to respect. So, identity and culture, religion, dynamics in terms of the way that somebody might approach mental health treatment or psychotherapy, and a lot of confusion because we know that the therapeutic alliance is really important to having an effective treatment plan. And so a lot of fear of damaging that therapeutic rapport, depending on how they respond. And then because we're the PTSD consultation program, everyone who consults is usually working with someone with PTSD. So a lot of confusion about the PTSD treatment plan. So do I provide PTSD treatment when they're bringing up something about the pandemic or about something that happened more day to day? And is this at all related to PTSD? So the goal of our lecture is to help provide some clarity and guidance in this way. So I'm going to transition now to Brittany, who's going to provide some strategies for addressing these clinician-specific reactions.
Yes, and we actually just got a great question in the chat. So my hope is to provide an overview of how do we respond to these difficult situations and sometimes challenging questions from clients. And then we can get into some of the specifics, like the question that Angel posed. So as Abby was alluding to, these reactions that can be evoked in us as clinicians can be confusing, sometimes disruptive and distracting in session. So this section focuses on what do we do with those reactions that are happening inside of us. So going to the next slide, this highlights how some of these decisions can be ethical dilemmas for us. So some of our identities that we might have that are cultural are visible, such as race or disability status sometimes, but not always. And we can also have invisible identities, and people might make assumptions that are inaccurate. There are other aspects of cultural identity that may not be visible, such as religion or political orientation, sexual orientation, and so forth. There's many, many ways that this can happen. And so if a client is making statements about certain cultural groups that is sensitive for us, they may or may not know if we're part of those identified groups. So then as clinicians, we can be in a dilemma of, should I share this part of myself? Is it relevant to the treatment? And sorry, the slides are going forward and I didn't want them to. Okay. So, so we can have an ethical dilemma about whether to broach the topic in therapy, wondering, is this relevant to why this client is coming to see me? And depending on the nature of the problem, the pattern, and the scope of it, we might even wonder if we're the right clinician to help this patient. So we'll also talk about some ethical decision-making related to whether we treat or refer. So regarding the issue of disclosure, there are some reasons why we might choose to disclose about our cultural identities, whether they're visible or invisible. Some theoretical orientations, for example, feminist or multicultural, relational cultural, specifically encourage clinicians to advocate for social justice. We've also seen an increasing number of professional organizational guidelines in their ethical considerations, such as APA, the American Psychological Association, updating their multicultural guidelines in 2017, which actively encourages people to be thoughtful of multicultural identities and how it intersects our therapeutic work with clients. There are also similar documents by organizations such as the National Association of Social Workers or American Psychiatric Association. Some authors argue that if clinicians do not address sensitive remarks, then there's an inadvertent collusion with oppression, and then these issues don't change and they continue. So another thought process is that if this is happening in the room with us as clinicians, this thought process might be happening with other people. So we can ask clients how similar interactions might be affecting their functioning, which is something we'll continue to build upon. On the other hand, there might be times that therapists are not sure if they should disclose their cultural identities. We're very cautious as therapists about doing no harm and about being beneficent. So we could be thoughtful and not want to impose our own values. We also might have concerns about damaging rapport with clients or being perceived as judgmental or racist or being perceived as overly sensitive. And many times, these types of issues related to the elephant in the room, sociocultural beliefs, may not be explicitly why a person is coming to see us. Particularly in this context, people might be coming to see us because of combat trauma or military sexual trauma, which may or may not be specifically related to sociocultural beliefs. So we can wonder, am I addressing this because it's important to me, or am I addressing this because it's important to the client? So Lee is one scholar that offers us a model of how do we respond to these types of questions. And he builds on Judith Herman's idea of a compassionate witness that she wrote about in Trauma and Recovery. And he illustrates how any person, whether we're a therapist, a client, a colleague, we might be victims, perpetrators, or witnesses when these microaggressions happen, or when there are these sociocultural beliefs that might be hurtful. So therapist as victim refers to the idea that we might have strong reactions based on our own personal experience and ideas, or if clients express a great deal of anger and we feel that we're being attacked. And in the victim position, we can feel helpless or be uncertain about how to respond, or it might switch us into the perpetrator role and then begin to attack the client. And that's not a helpful dynamic as victim or as perpetrator. There can also be being a witness to incidents like this. And the goal of being a compassionate, authentic witness is to maintain some presence and not be a uninvolved bystander, but to be able to reflect and observe what's going on for both the therapist and the client. So this is a way, a stance that we can explore our own thoughts and beliefs, also get into the thoughts and beliefs about the client, understanding more about the intent behind the statement, the function of the statement, how this might be happening in other relationships in their lives. So there's some specific guidelines of how to be a compassionate witness. We could think of them as do's and don'ts, and also things that we can consider while we're in session immediately, and also things to do outside of session. So a big part of this work is validation of empathizing, which can be very difficult to do if a client is espousing views that we find hurtful or offensive. So finding a place of trying to understand where the person is coming from can be helpful. Being curious, I wonder where that thought came from, or validating the feelings. I hear that you're angry. Finding some level of validation so it doesn't start off with just debative, combative interaction. Lee also talks about the concept of getting out of the way. Sometimes as therapists, we might take up too much space and relate to a concept and make it about our own experience or something that we've learned in the literature. So we want to be cautious about not taking up too much space and making sure that the focus is the client and their mental health and their relationships. Also being thoughtful about how we frame questions. Our wording can be really important. So for instance, if we lead with things that could be charged of, I wonder if you know that's racist, that can immediately set up some defensiveness. But really thinking about where the idea came from. I wonder, could you tell me more about what you're thinking when you said that? Exploring more about the thought process, and that can help us to not assume, as Michael McCarthy just pointed out, making sure that we are seeing what is happening versus getting into things like mind reading. Another helpful guideline is to practice mindfulness with our own actions rather than rushing to fix a problem. Many times as therapists, we are in the role of helper and we want to respond to distress or fix our own distress by taking action. So sitting and noticing our distress and reflecting the distress of our client can be helpful to be able to work through it versus rushing to a solution. We can also be mindful of the power dynamic as a therapist and a clinician, thinking about how our response can shape our clients' responses. We want them to feel safe in talking about thoughts and feelings related to these issues. If we send the message that it's not okay, then we could shut down important conversations and damage rapport. Can also be helpful to embrace learner's mindset, reminding ourselves that in all things we might not be the expert, particularly when it comes to cultural humility. We all have blind spots or hot spots or areas of lack of awareness, and acknowledging that and modeling that for clients to be able to facilitate a mindset of learning and growth. It can also be helpful to ask clients permission to express our thoughts and feelings. So for instance, I'm having a reaction to something I heard you say. Do you mind if I tell you what I am thinking about that? We also want to model acceptance of appropriate anger. So we do want to be cautious about not tolerating abusive language, but we could also validate anger and encourage people model how to express that anger in appropriate ways. Some things that we want to keep in mind as far as things that are not helpful under the don't area, we want to be careful about not asking the client to take care of us or not overusing our power and having them defer to us. We also don't want to blame clients and make them responsible for problems that they can't change or didn't create. So sometimes out of our own anger or frustration with things like racism, we can unintentionally send the message that it's a client's problem or not attend to some environmental aspects that make them feel like they are the problem. Instead, we want to find a balance of validation and empowerment, helping them to respond to what they can change and have acceptance or find ways to advocate for the things that they can. Outside of session, it's also important to seek support from colleagues. Many times when these incidents happen, clinicians might just keep it within themselves and it can fester, but being able to seek support from colleagues can be really empowering and validating. Coming back to that idea of the mask of accommodation, where sometimes on the outside we look okay, but inside we're really wrestling with strong emotions, it can be helpful to have awareness of the different masks that we've worn to function out of necessity, and sometimes where we put the mask on instead of acknowledging our feelings. Another helpful set of strategies comes from Gerald Wing Sue, which is one of the great leaders in the multicultural field who has talked a lot about microaggressions. He also talks about different things that we can do to respond to microaggressions and macroaggressions. Sometimes there's an idea that microaggressions are little and macroaggressions are big, but the way that Sue et al. Use it is to describe micro as more interpersonal reactions and macro as more person-society reactions. So micro doesn't imply that these are little things, but more the interpersonal level. So in 2019, they published a helpful article on how to disarm microaggressions and provided some very nice specific strategies. So I highly encourage people to look up this article to see some more examples, but I'll provide an overview here. So overall, there are 4 strategic goals. The first is to make the invisible visible. So thinking of the title of our talk today, the elephant in the room, actually acknowledging that elephant, commenting on its presence and its existence in a safe and empowering way. And sometimes that's difficult because we'd rather avoid what can feel like confrontation. But if we don't, as we've talked about, we can collude with oppression or not acknowledge our own feelings, which in itself can damage therapeutic rapport. So we can do this by pointing out different reactions or statements that might be made that can be hurtful or upsetting, or to ask questions about it. Another idea is disarming microaggressions. So part of the power of microaggressions can be how they can freeze us and make us unsure how to respond. So noticing that freeze response, but also working to overcome it, to acknowledge it. And sometimes this involves connecting to authorities, depending on what the situation or the context is. If there's a council within the VA that has guidelines of patient behavior, which we'll allude to in our case example later, for instance. Another strategic goal is to educate the person that made the microaggression or made the statement. Sometimes statements are made out of lack of information. And so providing more information about how a statement can be hurtful can be important. Or sometimes stereotypes can link certain behaviors to certain people, but those characteristics might actually be universal. So making comments about that. Another strategy can be really thinking about the role of intent, of asking the person, I wonder what you meant when you said this, or I'm not sure if you meant it this way, but when you made this statement, I had a reaction to it. And finally, the last strategy of seeking external support and reinforcement dovetails with what we talked about with Lee et al., which is knowing that we're not alone in dealing with microaggressions as clinicians, and that it can be really important to share with each other so that we can get it out in the open instead of just talking about it behind closed doors, and be able to have more productive, helpful conversations. So these strategies can be helpful when people are the targets of microaggressions, but can also be helpful for people that witness or are bystanders to microaggressions and allies as well. Another ethical issue we highlighted was whether to treat or refer. So here are some thoughts in guiding that decision. So we can consider still treating a client if the clinician is able to manage these strong emotional reactions. We are human, as it said in the comments. Even Rogers and his daughter had strong emotions. It's just part of being human. So if we are able to observe those reactions and process them, consult with colleagues, then it can still be appropriate to remain in the therapeutic relationship. Also, if there are limited alternatives, so there are some practical limitations, sometimes there may not be the ability to transfer to another client, depending on whether it's a rural setting or telehealth and so forth. We can also consider ways to incorporate these strategies into the treatment plan, and we'll go into some specifics of how to incorporate these types of issues in PTSD treatment plans specifically. There may also be times where even if it doesn't seem to fit as part of a treatment plan, we might assign assignments or encourage exploration between treatment outside of the treatment plan. On the other hand, it might be prudent to refer if this is a clinician hotspot. In other words, if this is an area where we feel really emotionally charged and it's a lot harder to manage our reactions, and we believe that we can't stay neutral, or we're so distracted by this happening that we're not able to focus and function as well as we normally can. Or in the event that the clinician has been attempting interventions, but the client's behaviors are not changing, then it might be important to refer. Another dynamic is if this is happening in the context of group therapy, thinking about the well-being of the whole group, that we don't want to condone abusive behavior or hurtful statements happening. And in that case, it might be helpful to have a plan to have individual therapy rather than a group. Lastly, we also want to think about self-care. So taking time to check in with ourselves. Many times as clinicians, we're very focused on the people that we see, which makes sense. And at the same time, if we overlook our own reactions, then it can contribute to the burnout we were discussing before, or lead us to act in ways that are outside of our values. We can also make sure to have a helpful work-life balance, and that might change from week to week. But if we overwork ourselves, then we can be more apt to succumbing to our strong emotional reactions, and not using as much care and caution as we would if we had more work-life balance. And as has been a theme, seeking social support. That might be our personal social support, our loved ones, our family or friends, and also professionally. So that can include local consultation with your team or at your setting, your practice setting, or as we talked about, also the PTSD consultation program can be a way to talk specifically about these case issues when they come up. And now I'll turn it back over to Dr. Ankow.
Great. And our third section is really going to focus on giving you all more tools. So Brittany focused on kind of immediate strategies, especially when you're having a strong reaction. And this section will focus on assessment and case formulation as ways to help build empathy, engender empathy in working with your patients, and help to understand a treatment plan specifically for PTSD. I'm going to wait until I have control over the slides. Here we go. And great. So the when we are talking about assessment, there are a lot of things to consider, which could include the impact of the client's beliefs on the clinician. So Brittany reviewed some considerations and suggestions for mitigating the impact on empathy, the impacts on communication, and the ability to provide good clinical care in the way that you want to. We can also assess the impact of the client's beliefs on their own mental health. So are the things that the client mentions, do you notice that her PTSD symptoms are exacerbated when and connected to maybe statements made about the pandemic or about current events, like heightened hypervigilance or avoidance? Specifically for PTSD? Are there other mental health impacts that should be considered here? And are you also noticing any change talk related to beliefs? And so change talk is very much like a motivational interviewing phrase, but are you hearing them mention that these views are having negative impacts on themselves, like they're having more conflicts in relationships that are important to them, and they're kind of talking about it in that way and kind of putting it on the table as something to potentially address? And then also we want to assess the impact of the client's beliefs on the mental health treatment plan, and hopefully using a shared decision-making process to develop a mental health treatment plan together. But are you noticing that potentially the client is less engaged in PTSD treatment or less connected to their goals related to PTSD? And are their views having a negative impact on the therapeutic dynamics and processes, specifically if you're in a group setting, as Brittany had mentioned? But those are all things that we'd want to assess. I'll use the phrases case conceptualization and case formulation interchangeably, but a case formulation is a way that to help organize and understand and hypothesize the origin, the current status, and the ways that mental health problems are maintained within a theoretical orientation. And so you'll notice case formulations are going to differ based on your own theoretical orientation. I can disclose that I have more of a cognitive behavioral theoretical orientation. So I'm often looking at kind of thoughts and behaviors, but anyone's theoretical orientation is going to impact potentially the way that they do a case formulation. And that the diagnosis alone is kind of insufficient to understanding the origin and the maintenance of mental health problems. So this is a model that I'm excited to share with you. That I like it because it's pretty straightforward and simple. There are a lot of different ways that you can do case formulation, but McNeil and colleagues in 2012 developed the 5 Ps case formulation model, where you consider what the presenting problem is, what are the current concerns, are there any acute safety issues, what are the predisposing factors that increase vulnerability or put the individual at risk of maybe developing further issues, what are the precipitating factors, so that kind of very recent proximal factors that triggered the onset of the current presenting problem. So we've been talking about the pandemic, so often the pandemic might be a precipitating or perpetuating factor, which are factors that maintain the problem. And then finally, protective factors. So strengths are factors that promote healthy and adaptive functioning. I mentioned that there are 5 Ps is just one example. I also wanted to share that Dr. Gail Iwamasa presented through the PTSD Consultation Program lecture series in October 2020 on a culturally responsive case formulation and different models. And I would highly recommend her lecture to learn more. And it's the recording is also freely available for CE credit. And good point, Michael, that pandemic really could take up all 5 Ps, especially as we're further into the pandemic. Brittany had mentioned that we are going to talk about a case. And so I wanted to share a case that I helped to consult on, that I also wanted to make sure to de-identify. So to illustrate these concepts, here's an anonymized case of a Mr. Arnold, definitely not his real name, and the patient identifiable information was changed. But in July 2020, Mr. Arnold presented within the VA healthcare system from primary care to mental health, which is a really common way to be referred. A 70-year-old white heterosexual cisgender man. And this comment was part of the referral from his primary care physician. So Mr. Arnold's narrative is peppered with inappropriate racist, homophobic, misogynistic, and anti-Semitic comments. He only wants to see a white male provider. And of course, he had a mental health intake with a white female clinician. So was seeing somebody for an intake that was not his preferred provider. His presenting problem at intake was, my life hasn't gone the way I hoped. I feel like I'm the victim of ethnic cleansing. He reported having unstable homeless shelter housing due to COVID-19. And that he was triggered by Black Lives Matter protests that were happening, because this was July 2020. And he stated, I walk around at night with my gun, hoping an N-word will start something with me. And he also stated, none of your therapists are white men. We're the largest group that serves in the military, and you don't have anyone there for me. So he continued to make comments, and these were shared by the consultee. He was diagnosed with PTSD and major depressive disorder, really a lifetime of multiple traumas stemming from childhood. And his primary index trauma was an assault by 3 Black men while homeless about 10 years ago. So using that 5 Ps model, I wanted to illustrate how this could potentially be helpful for trying to engender some empathy and also get an understanding of a PTSD treatment plan. So here are the 5 Ps. His presentation, so his presenting problems, and kind of what the therapist was noting was the use of aggressive and language that they found to be offensive about others different than the client. He also was having PTSD symptoms, nightmares, flashbacks about that assault, anger, feelings of unfairness, issues related to kind of homelessness, fear, and being fearful and vulnerable because of being homeless and an older adult, and also feeling isolated and lonely. He had several predisposing factors. So he reported having childhood abuse perpetuated by his father that he described as misogynistic. He described his cultural identity as a white minority in a racially charged environment. That's how he described growing up. He also stated that his military discharge was unfair, that he was discharged right before being able to retire, and that he perceived having a lack of support from the VA where he was receiving his care. So coming to the VA was a trigger for him. He was also chronically homeless for many years and was now ineligible, or was finding that he was ineligible for resources that were specifically allocated for ethnic minorities and for women. He described having no friends or family. And then, as I mentioned, he's an older adult, and he was also service connected and disabled. His precipitating factor was that assault by 3 Black men while homeless. And so this is where you might consider your theoretical orientation. So here is a kind of a cross-sectional cognitive behavioral formulation. So he has thoughts at the top, so that Black people will hurt me. I should have known they would hurt me, and I should have run away. And you could see that would leads to feelings like guilt, sadness, but also anger, fear, and vulnerability, and also related to the behaviors that he was sharing. So a lot of avoidance behaviors and aggression towards others. Perpetuating factors were the COVID-19 pandemic and housing impacts. He was in a very temporary housing situation where he was concerned about being evicted, kind of living in a trailer. Also the racial injustice protests were triggering for him, and being at the VA. But he also had some protective factors. He has adult children that he would like to connect with. And interestingly, he reported that many years ago in 2000, he had helpful therapy with a Black female therapist. So that was good to know that he'd had a positive therapeutic relationship. So I think creating this case formulation as a way to organize and provide some clarity to the potential origins and kind of understanding of Mr. Arnold's use of the language and the way that he was sharing his views about kind of sociocultural views also helped the therapist to build some empathy and caring for him and developing a treatment plan. And I don't want to suggest that all instances of a patient's sociocultural views are going to be related to mental health issues or PTSD, but assessing and creating a case formulation can help provide some clarity to the extent to which it may, if at all, be related. And then also help decide in terms of what are the primary presenting issues, what should you move forward with in terms of a treatment plan. So within a PTSD framework, we know that beliefs about safety, trust, and power and control often shift after the experience of trauma, and that these kind of views and concerns about current events might exacerbate those beliefs and exacerbate PTSD symptoms. So I'll transition again to Brittany to focus more specifically on PTSD treatment decisions after doing this case formulation.
So we'll be continuing with our case example here, Mr. Arnold, and talking about some different directions of ways to approach this across theoretical orientations, also in the context of specific evidence-based psychotherapies such as cognitive processing therapy, prolonged exposure therapy, and EMDR, and specific strategies for integrating these issues into the EBP if it's clinically indicated to do so. I'm trying to change this slide. Okay. So across theoretical orientations, these are things that can apply. So keeping in mind the things we talked about related to Lee and Sue, we want to make space to be culturally sensitive and work towards validation and empathy, understanding more about where these beliefs and feelings started and came from. So in the context of Mr. Arnold, seeing the case formulation and how some of these beliefs were directly taught to him by his abusive father, who he also described as misogynistic. And that can help us have some empathy of where these beliefs came from and help him move towards whether these thoughts and beliefs are helpful or not helpful. We also saw in the case example that he felt alone, isolated. He was a racial minority and around many other people from ethnically diverse backgrounds. So he felt misunderstood and excluded, which also contributed to his feelings and thoughts. There's also cultural templates, this idea from Lee of how we're socialized to behave in certain ways, sometimes explicitly, sometimes less explicitly, but that can have a influence on how we respond to people that are different from us. So our goal again is to build empathy, to maximize rapport, and asking for permission to share honest reactions as a clinician rather than just ignoring them or pretending that they're not there. Some of Mr. Arnold's behavior were therapy interfering. The referral note indicated that there were some other clinicians or staff members that felt uncomfortable around him. So thinking about how interactions like this can affect his medical care and educating the client on how such statements can be hurtful and harmful, and setting limits of not tolerating disparaging language, encouraging him to be assertive with his thoughts and feelings, but in a respectful way and not using slurs. And if there are client statements that can be connected to trauma and PTSD, then we can incorporate it into the evidence-based psychotherapies. If these statements are not directly related, it can still be helpful to provide education, keeping in mind Sue's strategy of providing education. And you can suggest follow-up resources between sessions, different readings or podcasts or videos that can provide another perspective. So going more specific into examples with Mr. Arnold, to address the limit setting, there was a disruptive behavior report and a disruptive behavior committee as part of this VA. So Mr. Arnold was oriented to the patient code of conduct, and he was informed that utilizing offensive language would not be welcomed in the clinic and could interfere with treatment. In this case, the patient responded to redirection and appeared to attempt to limit his comments on race, gender, and sexual orientation once he knew this information. And the clinician provided praise for his responsiveness, for using more appropriate language and not using hate speech. And he acknowledged, well, you asked me not to do that the last time we met. So he acknowledged the limit and respected it, which was progress. In this case, there was also a great deal of collegial support from the clinician seeing Mr. Arnold, seeking out Dr. Inkhau's support, for example, and the clinician received professional consultation throughout the process, particularly with limit setting, to make sure that the clinician was keeping the client's well-being in mind while also thinking about the institutional code of conduct. And this also helped to build empathy through the clinical case formulation for Mr. Arnold. So some particular factors that can be challenging with maintaining PTSD evidence-based psychotherapy and addressing other issues such as these sociocultural ones is a difficulty with time limitations. So for instance, prolonged exposure is usually conducted within 8 to 15 sessions. CPT might be plus or minus 12. So sometimes clinicians can feel, well, I only have a certain number of sessions, I can't address these things. Or reminding clients that we only have a limited number of sessions where we can be off protocol, but making a collaborative decision-making process is important. So, this particularly came up around the time of the election, as Dr. Ankow said, or with the multiple protests and different killings of Black and Brown people in the news. All of these things can cause strong reactions, and clients might come to session starting that way. So validating those feelings, but then asking, I can see this issue is bothering you, and we have a lot to accomplish. How do you think we should proceed? In some cases, the client might decide it is important to take a session to process the feelings because they're distracting. In other cases, just acknowledging the feelings could be helpful to the client, and they might be ready to proceed with the evidence-based psychotherapy more quickly. But really doing that collaboratively and making that decision together can be important. In the context of Mr. Arnold, both CPT and PE involve psychoeducation and providing insight about PTSD and how it can be connected to the different presenting issues. This can also be connected to the sociocultural issues that we're talking about. With Mr. Arnold in particular, validating how difficult it was for him to have emotional reactions to the Black Lives Matter protests and other trauma reminders. So validating the symptom and the difficulty without validating the hate or disparaging comments. Expressing that a goal of treatment could be to right-size thoughts and work on not overgeneralizing to make sure that the thoughts and beliefs are more helpful. Some strategies for culturally sensitive cognitive reappraisal can be having a rationale of addressing trauma-related thoughts. So these thoughts about Black Lives Matter also connect to the index event for him of being assaulted by 3 Black people. Another strategy is to phrase the thoughts that we're working on shifting, the target cognitions, to keep the focus on the client rather than debating sociocultural issues. So sometimes clients will get into beliefs about whether masks should be worn or whether the election was true or not, but thinking, what is the focus to the client? So I'm hearing you say this, and I wonder if you feel helpless, or I wonder if you feel powerless, and bringing it back to the context of the treatment specifically, focusing on the client's emotional reaction and connecting these sociocultural beliefs to the impact of the trauma and on the client's daily life. And in CPT, cognitive processing therapy, the recommendation is often to focus on what's called assimilated beliefs or trauma-related beliefs first. Many times these take the form of self-blame, such as I should have known they would hurt me and run away. So it can be helpful to address the role of context and pay attention to different thinking traps or cognitive distortions like hindsight bias. Sometimes using analogies like Monday morning quarterbacking can be helpful, and helping him see that at the time, he didn't have a reason to predict that the assault would have happened. In addition to trauma-focused beliefs or self-blame beliefs, in cognitive processing therapy, we're often addressing different themes such as safety, trust, esteem, power, and control. And some strategies in cognitive reappraisal can be pointing out times that he felt safe around people that are different from him, pointing out that risk can be independent of cultural attributes, So going back to the example of the helpful therapy in 2000 with the Black female therapist, there's also an idea of a trust star that sometimes we just come up with simple categories such as I can trust or I cannot trust. But interventions like the trust star show us the nuances, how we might trust some people with finances, but we might not trust those same people to be on time. Or we might trust some people with feelings, but we might not trust them to drive our car, and so forth. So using this concept and applying it to people that are culturally different from us can be helpful. And thinking about his prior therapeutic relationship in this case could be beneficial. For stuck points or unhelpful thoughts related to self-esteem or other esteem, there can be assignments to give and receive compliments to people that are culturally different from him, including people that he might normally omit, to help him attend to different information, and asking him if there's anyone that's different from him culturally that he respects, or anyone like him that is similar culturally who he dislikes, to separate the idea of cultural attributes and specific groups of people to personalizing more on an individual level. From a behavioral perspective, where this might be applicable to prolonged exposure therapy or other interventions that use in vivo or in real life exposure, encouraging Mr. Arnold to interact with culturally different people in safe places. So this might include places like the grocery store, or depending on the person's comfort with the pandemic and social distancing, it might be relevant to go to different places within the VA, such as waiting rooms, or interacting cordially with culturally different staff, or encouraging people to connect with people from their background. Have you ever had a past comrade that was culturally different from you that you really related to, and encouraging them to connect? Another big part of prolonged exposure therapy is processing the trauma. Sometimes this overlaps with the concepts we've talked about, such as power, control, esteem, so forth. We can also explore the origins of beliefs, whether these sociocultural beliefs started before the trauma and were part of cultural socialization growing up, or whether they were more driven by the trauma in the context of the fear and the index event that led them to seek treatment. And also talking about that concept of cultural scripts can be helpful. Often using language such as how valuable or how helpful is this belief can be less charged than how logical or rational is it. So that can be a way to explore these beliefs with sensitivity. Again, the theme of building empathy and looking for validation, providing validation, and desiring to connect with culturally similar others. When Mr. Arnold mentioned that he wanted a therapist that looked like him, and that's understandable. And also valuing when that's not possible, that it can be valuable to connect with others that are culturally different. And for eye movement desensitization and reprocessing therapy, there can be some treatment plan considerations. So similarly, there can be a history and preparation phase where we provide psychoeducation and also address sociocultural beliefs. There can be flexibility in the initial phases of EMDR while obtaining the presenting problem and related behaviors and symptoms. As we've talked about, many clients will express their cultural beliefs, and inviting that in a respectful way. Also, using strategies such as mapping out the problem or choices have consequences can be helpful. In the fourth phase of EMDR, which is desensitization, which involves talking about the trauma and its impact, focus sets of BLS to aid in linking adaptive information, increasing ability to differentiate between the context of the trauma and what happened at the time compared to now, and working to reduce overgeneralizations, which is similar to the concept of right-sizing beliefs like we talked about. Associations might not always be positive. The client may demonstrate some improved self-awareness and later on have guilt regarding behavior that might be perceived as helpful or unhelpful or offensive. And that could be seen as adaptive because the client is taking responsibility. These different sociocultural beliefs sometimes might create blocks, looping abreactions, and interweaves may offer opportunity to rephrase or reappraise cognitions to keep the focus on the client rather than debating or externalizing. So again, a theme we've seen, allowing space for all reactions and emotions and exploring what are the fears and emotions underneath. So in sum, our goal today was to highlight that patients will share their beliefs related to sociocultural concerns and stressors in PTSD treatment, to normalize that clinicians may have strong emotional reactions to these beliefs and difficulties due to our own personal reactions as clinicians, to consider how this can affect ethical decision-making and to provide culturally responsive approaches to guide reactions, to provide some specific assessment and case formulation with the 5 Ps of how to build empathy and consider how the sociocultural beliefs developed over time and can impact PTSD treatment. And then also some specific treatment plan strategies, whether we're using cognitive, behavioral, or EMDR approaches, and things that can be used across theoretical orientation. And also a reminder to practice self-care and seek consultation, to not operate in a silo when these issues emerge, to empower yourself to respond. And I'll turn it over to Dr. Engkow to go over some resources before we open it up for questions and answers.
And we thank you, Brittany. And we also wanted to share several resources related to current sociocultural events in case they may be helpful in your work. So we work with the National Center for PTSD, and they have many COVID-19 resources. We have a webpage summary of what to expect with regard to the impact of PTSD. I wanted to highlight the lecture series because I had referred back to a lecture that Gail Iwamasa had given on case formulation, but we've also had several lectures on a lot of current events recently, and all of these are freely available and recorded. We also referenced the multicultural guidelines, and we've provided a link to the APA ones. And Dr. Hall Clark referred back a few times to Lee 2005. So we wanted to give this direct reference. I know there should also have been a reference list that attendees have access to, but this Lee 2005 also has a lot of case vignettes and reflection questions that may be helpful. And I mentioned our resources for COVID-19. There are actually 34 pages of resources across 3 domains for everyone, for healthcare workers, for employers and community leaders, from very basic questions about how to address reactions and prepare, how to provide stress first aid, also how to help people to wear face masks if they need to or want to. I also, there's an image of COVID Coach, was developed by the VA, and it's a mobile app that people can use to help with coping during COVID. And these are all free resources. And then we also have we have a research quarterly, and specifically issues on racial trauma and racial and ethnic disparities in PTSD may be helpful, and several more web pages related to current events like wildfires, what to expect following violence, a provider guide, and web pages for racial trauma. And then finally, Brittany and I both work for the PTSD consultation program. We'd like to end by inviting you to contact if you find that it may be useful. We're a free service for any providers treating veterans with PTSD, and especially during this time when clinicians and our colleagues may be experiencing or concerned about burnout. We want to be able to help by helping to find resources or help with consulting, especially any potentially challenging situations. Thank you all so much for the work that you do and for attending our lecture today.
Well, I wanted to thank the both of you for an outstanding, super informative, and actually really, really practical lecture. Lots of actionable intel in what the two of you were able to speak about today. And I really appreciate the inclusion of a model to use to begin to conceptualize some of these difficulties so we can start to weave them into our clinical work. So really, really useful. Thank you so much. To be honest, the both of you did a fantastic job of responding to questions as they were coming up. And so there weren't any additional questions that weren't answered already in the chat. We do have a couple of minutes if there are additional questions for folks. Um, I'm seeing a lot of thank yous and appreciation and gratitude, which is wonderful.
So I wanted to highlight Angel's question, which was, how do you balance the thinking or comments of our society becoming oversensitive? So I think, if a client asked that, I would be wondering about the feelings underneath that question, wondering if they felt attacked, if they made a certain statement, and look for the origin of that belief, as we've been talking about. Also exploring the nature of the relationship, whether it was a family member or someone they have a close relationship to versus a stranger could make a difference. And applying the different strategies we've been talking about here to ask about what the situation is and if it's something that they would like to change as far as being able to improve the relationship with that particular person.
Good catch. Actually, I had forgotten that you said you wanted to get back to that one, so thank you for remembering that.
Sure.
And also, a question from Danny in the chat flew by, so I'm just going to repost that for you. I thought this was an interesting question.
Let's see, I'm reading over it now. Dr. Incal, let me know if you want to respond first this time.
Sure. So I had a client who made insensitive statements and then would follow it with, but I'm not racist. So my assessment that his beliefs had a lot to do with his deployment experiences. How would you respond to his response around I'm not racist? So I would imagine that perhaps the clinician may have a reaction to potentially both the insensitive statements and the follow-up statement, but I'm not racist. But I really appreciate that there's an assessment here, so that conceptualization that his beliefs might be related to specific deployment experiences, and then in the context of we're going through how this might be currently exacerbated. I might pause and it's hard without context, but really think about the context in which the statements were made, and then if comfortable, you know this may just be more my style, but if the clinician has a reaction, you might ask, for I tend to ask for permission, like, is it okay if I share? I found myself have a reaction to what you say. Can I share what my thoughts, and I'm wondering about. So, really coming from like a learning kind of witness framework that Brittany had described. And then I think that would hopefully elicit in a non-confrontational way more information that will help to kind of frame where to move forward. Brittany, what would you add?
Yeah, I think that makes a lot of sense. I think about too, the idea of thinking traps that can come up and how one of those thinking traps can be labeling. And if other people are labeling him as racist when he makes these types of statements, I can understand how that leads to frustration, or if he's worried that people will have that perception. So I think, again, going back to his intent of what the statement is and what was his intent by making the statement could be helpful. And then also thinking about how his beliefs could be connected to his day-to-day symptoms. So for instance, it's common for our veterans to have beliefs that are associated with people perceived to be Muslim or Arab American and wonder if they are dangerous. And so validating the fear, but also paying attention to right sizing the situation if they're going to the grocery store and being open to the idea that the person could be safe or that the environment could be safe, for instance.
Well, thank you so much for being willing to answer some of those questions on the fly. We definitely appreciate your expertise. And thanks again for such a wonderful presentation today.
Thank you again for having us.
Yes, thank you.
You're most welcome. Don't be strangers. We'd love to have you back at some point.
Mhm.
I'm going to hand things over now to Mr. Norgard, who's going to tell us all about what we need to do to get our CEU credits.
Thank you, everyone. So here momentarily, let's go ahead and just advance the slides so that you see it. If you've attended before, you already know, but if it's your first time, welcome again, and thank you for joining. In about 2 hours, the attendance should be taken. Sometimes it's far less than that. Sometimes it's only about 10 to 15 minutes, but we at least ask that you wait about 2 hours before you start sending those emails. If after 2 hours, it still says that your seminar is not complete, go ahead, send an email and we'll take care of that for you. If you have any questions on how to complete the CE process, again, my email is up on the screen there. And yeah, thank you again for showing up today. And if you have any questions, please make sure you put them in the chat. We'll keep the room open for the next couple minutes.